Welcome to The Explainer. Today we're unpacking a physical reality that is just fascinating and honestly pretty deeply misunderstood. If you've ever watched a patient with severe chronic obstructive pulmonary disease, COPD, you might have noticed something that looks almost entirely backwards. Think about it. For most of us, breathing in is the part that takes effort, right? And breathing out, that's just passive, it's effortless, it's automatic. But for this patient, the reality is entirely flipped. Exhaling is actually the single most engineered, deliberate act of their entire respiratory cycle. So, you might be wondering, why is exhaling the hardest part? You'll often see these patients deliberately pursing their lips just to breathe out. It literally looks like they're struggling to push the air away from them. And that one specific detail, that exhalation, not inhalation, is the real crisis in this disease, is kind of the skeleton key that unlocks almost every single physical sign you're going to find on an exam. Okay, let's dive into this.
To get a full picture, here's our roadmap. We're going to cover the pursed lip paradox, the first principles of COPD, the flattened diaphragm, the brand new 2025 GOLD guidelines, and finally, the finger clubbing trap.
Section 1. The pursed lip paradox.
At its core, COPD is fundamentally a disease of expiratory airflow limitation, and it's driven by two major factors. First, you've got small airway inflammation that physically narrows the tubes, and second, there's a loss of elastic lung recoil, which is caused by emphysematous destruction. Think of a healthy lung like a fresh balloon, right? It naturally wants to snap back and push the air out. But in COPD, that elasticity is destroyed. The lungs just can't empty properly. Because of this, a stubborn residual volume of trapped air gets left behind before the next breath even has a chance to begin.
Section 2. First principles of COPD. Let's actually follow the physics of this disease step by step, because it's a real domino effect. Step 1, the small airways narrow. Step 2, the lung loses its elastic recoil. And because of those two factors, we hit step 3, exhalation becomes incomplete. Now imagine this happening breath after breath after breath. That trapped volume just keeps accumulating. And this leads directly to step 4, progressive hyperinflation. The chest literally becomes barrel-shaped from all that persistent, stubborn trapped air. It's crucial to understand here. It's not air hunger, it's air trapping.
Section 3. The flattened diaphragm effect.
Now, all this trapped air creates a pretty fascinating physical effect. Because the lungs are hyperinflated, they permanently push the diaphragm downward, completely flattening it out and essentially robbing it of its normal mechanical advantage. Because it's sitting so incredibly low, when it flexes during inspiration, it physically drags visible structures down with it. This is what causes Campbell sign, or a tracheal tug, where the trachea is actually pulled downward with every single breath. You can also see Hoover sign. This is where the lower ribs paradoxically draw inward instead of expanding outward, all because that flattened diaphragm is just pulling them in. To compensate for all this, patients often adopt the tripod position, leaning forward on their knees. Doing this mechanically fixes the shoulder girdle in place, freeing up their accessory muscles to help them heave that chest open. And, well, this brings us right back to our original hook. Why the pursed lips? It's not just some nervous habit. Exhaling against partially pursed lips actually creates back pressure. That back pressure travels down into the lungs and physically splints those small airways open longer. It prevents the premature dynamic airway collapse that traps the air in the very first place. So this patient is basically using a mechanical life hack to lengthen their exhalation, improve ventilation, and reduce their CO2. It is an absolutely incredible physiologically informed compensation. So how do we end up here? Well, tobacco smoking is for sure the dominant global risk factor, although indoor cooking smoke from biomass fuels is massively important worldwide too. There's also a small genetic minority driven by alpha-1 antitrypsin deficiency. If you're listening to a patient's chest with a stethoscope, this hyperinflated state means you're going to hear globally reduced breath sounds, simply because that trapped air is a terrible transmitter of sound. You'll also likely hear a hyper-resonant percussion note, and maybe some early inspiratory crackles from airway secretions. But here is a really high-yield fact for you. If you want to know what the #1 predictor of a future COPD exacerbation is, it's a history of a previous exacerbation. Past behavior predicts future risk more reliably than almost anything else. Section 4, the 2025 GOLD guidelines. Okay, we are looking at a massive shift in clinical management here. For years, the framework used a 4-group ABCD grid based on both symptoms and exacerbations. But recently, this was totally overhauled into a 3-group ABE system. Why? Well, Well, because they realized that exacerbation history is just so incredibly powerful. The old group C and D, which were the high exacerbation risk categories, were merged into a single group E. Once a patient has had 2 or more moderate exacerbations or just one that requires hospitalization, their risk category dominates their treatment plan, completely regardless of how symptomatic they might feel day to day. Now, just to clear up any potential confusion, while the letters change to A, B, and E, the spirometric grading based on percentage predicted FEV1 remains exactly the same. You still have GOLD 1 through 4 to measure the actual degree of airflow limitation. You simply combine the spirometric grade with the new AB group, so a patient might be classified as, say, GOLD 4, Group E. The absolutely crucial point here is how this actually changes treatment. Group A starts with a bronchodilator. Group B, who have higher symptoms but a low exacerbation risk, start on a long-acting muscarinic or beta agonist, a LAMA or a LABA. But Group E, our high-risk group, starts on a LAMA plus LABA combination right out of the gate. And here is the really vital update. You only add an inhaled corticosteroid or ICS if the patient has an elevated blood eosinophil count. We don't just reflexively hand out an ICS to every high-risk patient anymore. We use blood eosinophils as a very specific biomarker to predict who will actually respond to it. Real quick, if you're ever struggling to distinguish COPD from asthma on a pulmonary function test, remember this fundamental difference. Both of them might show an obstructive pattern where the FEV1 to FEVC ratio is below 70%, but COPD shows limited reversibility after giving a bronchodilator and, crucially, a reduced DLCO, which measures diffusing capacity because the emphysema literally destroys the alveolar surface area. Asthma, on the other hand, classically shows significant reversibility and usually preserves that DLCO. Section 5. The finger clubbing trap. Listen closely to this one because I cannot emphasize this enough. COPD itself does not cause finger clubbing. It's a highly tested misconception, and honestly, making that assumption is a critical clinical error.
If you are examining a COPD patient and you happen to find clubbed fingers, your alarm bells should immediately be ringing. That finding points to a serious complication. The most important culprits you need to suspect are lung cancer or bronchiectasis. Remember, COPD is a profoundly systemic disease. It causes muscle wasting, osteoporosis, cardiovascular issues, and it shares the exact same smoking-driven carcinogenic risk substrate with lung cancer. But the COPD didn't club those fingers. Something else did.
So, the next time you see a patient pursing their lips, leaning forward in a tripod position, or exhibiting a tracheal tug, don't just memorize a list of disconnected signs. Trace them all back to the first principle. A lung that can inhale just fine, but has genuinely lost the ability to fully let go. It's a breathtakingly logical chain of events once you understand the physics of trapped air. And that is COPD built from the ground up. Does viewing this disease through the lens of trapped air rather than oxygen hunger change how you're going to approach your next patient? We'd love to know, so let us know in the comments. Please like the video, ask any questions you have down below, suggest future medical topics you'd love to see us decode, and make absolutely sure to subscribe so you never miss an explainer. Until next time, keep questioning how things work beneath the surface.